Living Seed Media brings to you God's Word, which is His comprehensive equipment for changing lives. May the Lord impact your heart as you encounter His Word. For further inquiry or counsel, contact Peace House, P.O. Box 971, Boko, Benue State, Nigeria. Telephone numbers 0703 0363659, 0703 7681198. Email address lsmedia@livingseed.org, or visit our website at www.livingseed.org. Let us sit back and listen as the servant of God brings forth the word of life.
So our next presentation is going on the back of what our brother just concluded on, community health financing. If Emmanuel had a health insurance, he would have gone there earlier enough, but he didn't have. And then they had to pay 100,000 naira. And that's a lot of money in a time of emergency. So we're going to be looking at community health financing. And for that, we have our brother, Tope Adeni. He is the CEO of AXA Mansard Healthcare, which deals with health insurance. He's an IT expert, but currently works as the CEO of AXA Mansard. So, Bro Tope.
Okay. Thank you very much. I hope you can hear me.
Yes, we can hear you, sir.
All right, thank you very much. And I'm very excited to see another healthcare conference, Christian healthcare conference. And maybe as always, I'm about the only non-core clinician that comes for a healthcare conference. I hope there are many more who are specialists in healthcare statistics, healthcare administration that don't really touch human body. Thank you very much for that great insights, Professor Choma. I think I will start from where he stopped. He had basically covered majority parts of the core pillars that I would like to talk about today. I'm happy for the inclusion of this, as we all know that healthcare is so important, and majority of our people will not be able to afford the cost of healthcare at a point of care. Most people do not plan to pay for any healthcare. Rather, they think nothing like that would happen. And so people hardly prepare for such emergencies that may occur on a deteriorating healthcare. I just want to share the slide right now. So briefly, we're going to be looking at community health financing. My outline, we go through these points. We look at the overview of healthcare financing, the health insurance overview, community-specific healthcare financing, the issues around it that will make it effective and properly delivered in the community, and issues of challenges and how do we mitigate them, and what I will see as recommended action plan for us as we collaborate together as healthcare workers. Let me start with this introduction by using our familiar parable, the Good Samaritan. This is a very popular parable of the Lord Jesus Christ that actually connotes a lot of things, a lot of messages for me. But for today, I just wanted to draw the issue of practical healthcare from it. So the Samaritan man saw a man in need and stopped his journey to care. I'm sure he wasn't a doctor. I think it was just a merchant. So, but he always traveled with basic items that could give first aid. So he used the wine, the water, the oil that was with him to anoint the dying man And so he offered the first non-professional care, first aid. So Samaritan man cared for the man, and he took him on the horse. That's an ambulance. He took him by ambulance and took him to the inn, which is the clinic. The clinic is the professional center, which like our medical primary health care center or secondary health care center or hospital or a pharmaceutical that could actually do a little bit more than what a mere first aid person can do. Not only that, he decided to pay for the clinic. So he paid for the cost of care, and he told the clinicians, I'll come back again. Whatever else that you really need to spend on this man, I'm going to pay. And he came back, I believe, and he paid the balance. So we saw from that parable that healthcare has a cost. Healthcare is paid for by someone. It does not matter whether it's the direct person or someone else, but healthcare is paid for by someone. Even when God does miracles, somebody pays for the cost of that miracle, which is the Lord Jesus Christ. So God heals through miraculous interventions, as we see from the word of God, and every day he does it. The same way, the same God, he also does heal through caregivers. And these caregivers who are like, when the Bible talks about balm in Gilead, people who provide care for the sick, for the patient, for the people that require that help for their body or their mind in order for them to be restored back. And as we have defined healthcare to be a comprehensive state of well-being, spiritual, mental health, and physical health, so also we see the caregivers as people who also render this care while God ultimately heals. The point there is this: God heals by direct miracle as we pray. God also heals as when our healthcare workers contribute their care process and in a coordinated manner, and God still brings healing. When this happens, somebody pays for the cost of healthcare. So healthcare financing is either prepaid or postpaid. In the case of Good Samaritan, it was postpaid. The only thing that he prepared for was the wine, the oil, and all the items he used to take care of this man. So in either case, either post or pre, healthcare is being paid for. And it's a form of good-heartedness for the man when you make contribution to someone who might fall ill. Sometimes people don't like to talk about health insurance because they believe that means you are preparing to be sick. Not exactly, in my opinion. I think it simply means that you are contributing to someone that may need it. It doesn't have to be you. You are simply contributing to someone that may need it. In fact, it is good for you to stay healthy so that the few people that get healed can actually experience the goodness, and through that, they can also be drawn to the Lord. The message of day 2 was talking about the preparation of all the areas of healthcare because somebody might fall ill, and that's why God provided the blood of Jesus Christ as a continuous cleansing agent for us, even though it doesn't want us to commit sin, but somebody might still fall into sin. So not necessarily because you're expecting to be sick, but you make contribution to take care of healthcare needs of those who fall ill. So the principle of healthcare financing from insurance perspective is the healthy paying for the sick, and also the healthy also paying to ensure preventives as well as supportive care when there's a need. So for us, it's an opportunity to serve the community, which Prof has defined in various perspectives earlier on. Community can be our church institution, can be the locality of geography where we operate from, can be a network of our contacts, can be it can also be a political, demarcation of a particular area. So every area of our contact that we are in, that's a domain of our influence, represents a community that we can actually structure an effective healthcare financing program for. Let's quickly look at the challenges, which I would not want to bother us so much again, as we have gone through this over and over, the challenges of healthcare in developing nations. We know that in developing countries like ours, there is inadequate funding of public health facilities, even though all the nations will say that there is inadequate funding. but we know our own is really, really very, very peculiar, as it's quite very low. And that leads to low quality of care. Also, it leads to low motivation of the healthcare workers. It leads to so much problems that continue to cause real problems in healthcare. And also, there's no access to healthcare by majority of the population. Even though the government of Nigeria, for example, spend about 2.5 trillion naira on healthcare, this is not experienced by up to 25% of Nigerians by the government spending. So it then means that the majority of people actually spend out of pocket to pay for their healthcare. Reducing, again, some of the problem this happens is that the quality of our personnel, medical personnel, continue to degrade because motivation reduces, and there is no incentive, there is no, there's no passion anymore. The passion has drastically reduced. People actually just think about money, just think about immediate reward, just think about instant gratification on healthcare. Again, we see medical tourism, where I sit, I see a lot of hundreds of billions or hundreds of millions going out of the country for medical tourism. And that doesn't really solve our problems. By the time pandemic hit us, there was no place to go because everybody was struggling with their own healthcare system. And because of all of the challenges, we are seeing proliferation of quacks and non-licensed medical practitioners. This again continues to cause worse things in our healthcare system. Indices have gone terrible. Life expectancy is about 54 in Nigeria, particularly. A few countries in Africa has much higher, but Nigeria is particularly low. Now, there are two sides of the healthcare chain. There is what we call the demand side and the supply side. A lot of our discussions have been on the supply side, which is talking about all the various structures that deliver the core healthcare itself. The clinics, the hospital, the primary care, the physicians, the pharmacists, the diagnostics, the nurses, all of the people that actually perform the healthcare system itself. The operations, all of the procedures, those are the supply side. The supply services, they touch the patient. They came up with the drugs, they administer the drugs. They bring patients from state of illness on the state of good health. That's supply side. Then the second side of healthcare, and that's the demand side. Demand side focuses on aggregation, structuring the consumers of healthcare in order to optimize quality, increase access, and minimize costs. And that's where healthcare financing comes in. It is the demand side. And it's the demand side that normally pulls the public to be able to have good access to care that will improve the quality of the supply side ultimately. If the demand side is not properly structured, the supply side will continue to experience problems. Nations that have advanced in their healthcare realize that the demand side must continue to attract more people into the pool with ability to be able to pay either by government or by individual or by corporation in order to be able to sustain quality in supply side. And we'll see that nations like Netherlands, UK, some European countries that have nearly achieved 99% universal health coverage, they actually have prioritized the demand side. And that's why they are able to have at least best of care and best use of their money for the basic healthcare cover. So both of these two sides of the chain must be well integrated, must be well coordinated together to be able to achieve universal health coverage. So healthcare financing, therefore, is a function of health system concerned with both mobilization and allocation of funds to cover health needs of the people, both collectively and individually. So if this is not done, what normally happens is that the challenge it comes to the community is that it leads to bankruptcy. Sometimes people cannot just do their work anymore. Their health fails, and so their business fails. They sell their little resources, land, housing to pay for healthcare, and they become broke, and life expectancy further worsens, lifestyle further worsens. And you can see from the example of Emmanuel, the man had no money, the young man was not insured, and if not for the mercy and intervention of God, the boy would have just lost his life. We have many hundreds of thousands of such people that lose their life because there's no way for them to survive, nobody to be able to stand in for them to pay. And there is no way except the Lord intervenes through such brothers and doctors who could pray, who could intervene even without collecting money like that. Sometimes it also leads into financial indebtedness, and it leads into fatality due to the use of self-medication. People end up administering, self-care, inappropriate medical interventions, and they worsen the condition. So let's quickly look at different models that we can use to finance healthcare. The first one is out of pocket, which is not the very best one. Out of pocket means you have saved your money, and anytime you need healthcare, you pay for it. That's what majority of the people do, but it's not very efficient because people normally will not go for basic healthcare when they are sick. So a lot of times, people's condition have gotten terrible before they appear at the hospital. People would have used all sorts of things, self-medication. They would have used, sometimes they would take anti-malaria for anything. Any slight headache, just reach out to get an anti-malaria. Tummy ache, it's like, see if there is one drug that solves all problems. They can go to the patent store. That's even somebody who even believes in orthodox medicine. Otherwise, they can use all sorts of unorthodox drugs and buy it, or prayer houses and get it and buy such things, and then worsen the healthcare condition that he or she is. By the time he appears at the hospital, things have gone terrible. So out of pocket constitute today about 76% of Nigerian health expense channel. The second one is health insurance scheme. Health insurance schemes means a prepaid scheme where people contribute ahead just in case they will require healthcare in the future. An health insurance scheme can be private or social. The private means the ones that is done by employer, done by community, or by an individual. It can be employer-based, can be community-based, and it can be individual-based. While the government type, which government pays for the maybe the workers of government or a particular community, is called the social health insurance. Other means that people use for healthcare financing include health savings scheme, where they save money like an isusu sort of things, where people gather their money on a periodic basis and they allocate a portion of it for health. In some countries like Kenya and some other countries that are embracing technology, they are beginning to put some fund into their health wallets called digital health savings, in which whenever they fall ill, they can have access to it. And the final point is when healthcare is fully subsidized or fully taken care of by the government, maybe like the case of NHS in London, in which case everybody that is a citizen has access to NHS. But that also is funded through individual tax that the government collects. So we focus our health insurance in this paper on the community health financing, which is a private health scheme. So as we look at this various way, the benefit we get when health is properly financed through an health insurance method, be it community or individual, is that there will be equity in healthcare contribution and distribution. You will have a lot of people in a community to be able to have access onto equitable healthcare. There will be free access also at the point of care. So when people they fall ill and they need to have their health attended to, they would not need to be looking for money, because at that particular point in time, there may be no money. So when we are prepaid, it enables people to have access to care, and they can actually show up on time. They can come for preventive health check, they can do health tests, they can come for simple things that can prevent major things from happening to them. So we are going to have healthier community and more productive community. We're going to avoid all of the problems which are earlier on mentioned about financial laws, about complicated healthcare and social problems as well, because you have actually taken care of those health issues ab initio. Current health insurance penetration in Nigeria is actually just about 5%, only 10 million out of 200 million people. That's one of the lowest also in Africa. African average is about 8%, but Nigeria is just about 5%. And that again is to show us when we see all of the outcome or indices of health very low, one of the reasons is because health insurance is also very, very low. Now, community health insurance programs are quite few today in Nigeria because there is huge knowledge gap. There is also a problem with the economic ability of the people, and there is lack of enabling structure, among other challenges. but it is not insurmountable challenges, which is why we are here, to be able to look at what can we do together to be able to create community health insurance pools that will be effective, that will be useful, and that will be able to serve our people and become a channel for us to have more demand for healthcare that can enable us to reach out to people, in fact, to reach out now to their spiritual health condition. We also have the other challenges that my previous speakers have talked about in terms of facility and all of that. Now, on community health insurance, there is a peculiarity about it. First and foremost, most of even the medical personnel, they do not spend time to look at insurance as a key factor of helping to address community health needs. And so there is a huge knowledge gap. There is a huge knowledge gap in the community. There is also knowledge gap about the medical personnel. And also, you also realize that there is a huge distance between the healthcare facilities and the community in many instances. So you have primary health center that is about more than 5 kilometers to the community. And many of the primary health care centers, they do not even function. So people don't even have access to the care. So for a community health insurance system to work, there must be an effective functional healthcare center that will be able to meet the needs of the people. There must be effective, coordinated healthcare center that will be able to deliver the promise to the people. That is going to increase trust, that will increase adoption, that will make more people to come into the health insurance scheme, and it will improve overall adoption or overall consumption of proper health care. Now, I would like to look at the structure that makes community health care work effectively. So for us to have effective community health care, the first and foremost issue is about those who run it. My little experience over the past 7 years in health insurance space has shown that what makes health insurance work primarily is the quality of the people that run it. I started working around health insurance as a complete non-medical person, but I came, into the industry to look at some problems can be solved, and we can actually increase and improve the quality of healthcare as well as access to healthcare. And of course, as a child of God, I pray, and I was properly guided by the Lord, and that's very important. Discipleship is always very key and central. And I entered into things I knew that I did not have a full, medical knowledge. Of course, I didn't have medical knowledge, but I understand that healthcare is beyond just clinical. Healthcare is about well-being of the people. So having prayed and having entered into the system, I saw that what is first and foremost needed is right people that are passionate, that are men and women of integrity, who can be trusted, who are ready to passionately commit themselves to serve the people. And the Holy Spirit told me, I said, don't think of premium first. He said, care first. Think of care first. Premium will follow later. So I wasn't even sure I was going to be able to run a profitable company, to be honest. I thought maybe I was just going to have a company, and if it doesn't work out well, I would jump out again, I'll go back to my technology. But lo and behold, within a space of 2 years, I saw amazing things happening. Commitment to that care, commitment to integrity, commitment into doing things well, just changed the system completely. And within a period of 5 years, every health insurance system I met on ground became behind me. They just fell behind me. And everybody was watching, what's going on? All of the people, what's this guy doing and his team? And I just realized that what will cause a transformation in any sector is first and foremost trusted men and women, people who are committed to selfless, passionate service unto God and to humanity. And that is what I've experienced in the last 7 years. By the time we took leadership over the general health insurance system with a bigger community, not a local community now, this is a bigger community that spans across the nation. And then we decided that, okay, it is time for us to now do smaller community that will be focused and closer to the people. And the same principle has started to work, meaning that it works at a larger scale, and it's going to work at a smaller scale as well. Men and women of integrity, people who are godly, passionate, ready to lay down their lives to serve the interests of God and serve the interests of the people. Also, the second thing I saw that would be very effective is enabling governance structure. We must have proper governance. It means that we cannot be lord and master in the structure of any health insurance, particularly in community health insurance. We must include all the stakeholders that we're going to make it effectively delivered. The stakeholders will include the head of those communities, maybe the village head, if it's in the case of a village. In the case of an institution like a church, for example, recently I was able to structure an health insurance system for the entire pastorate of the First Square Church Nigeria. That's a community of its own, but a bit wider. And you just have to have a very effective governance structure that will make everyone to be accountable, that will make it to be transparent, and make everybody to be able to trust. It will be a fail-safe system. It will be a system that has controls. It will be a system that is well designed to be able to cater for the people, and it can be easily monitored, and the performance can easily be measured. Number three, the third thing that is very important is data. And Prof has talked about data earlier on as well. Data, data, data. Health insurance writes on data, feeds on data, and delivers on data. Every functional health statistics is going to be useful to be able to design effective health insurance system. We must have data on the disease burden in that community, data on the cost of care in that community, data on the demography of the community, data on the challenges the community experience. Do we have sanitation challenge? Do we have likelihood of epidemics? Do we have different issues that we need to have data on? And of course, as care begins to be rendered, we must also document all of the data about the patient in order to be able to enrich the design of future benefits and future cost of care for that community. The fourth one is good payment system. In the past, it is very difficult to have good payment system because it would be so manual. But today, there are more effective payment systems that community can sign on to. And that's why anyone organizing community health insurance must actually be very tech-driven, tech-centered. You have different organization, mobile money agents. It's very much advanced also in Kenya, where you have a lot of that mobile money agents, and they are really, really working. In Nigeria as well, we have over 300,000 mobile money agents in Nigeria who are using technology through their phone to be able to collect money, to be able to do a lot of transactions. These are all payment systems that can now be used for community health financing. People can sign on to it and get their wallet debited on a regular basis and be paying in installment into their community health wallet. And that way, you are able to aggregate those funding. So we must have good payment system to be able to do effective community health insurance. Of course, technology drives the whole scheme. And it's not have to be expensive technology. Technology can be so simple that we'll be able to get all the basic data required across the value chain, both at the clinical side, as well as the payment side, as well as even communicating with the community, with the members who have subscribed, because the health insurance is going to include not only in the curative side, also preventive. Education of the public will happen through that communication channel. Be able to tell people information about diabetes in their various local languages. You'll be able to give them pictorial information for those who have data, telephone that has some data capability or visual multimedia capability. And you can also record voice note that teaches basic things on preventive healthcare and send to the people. And that will be very helpful. The final one is regulatory support. And of course, I must say that the finance speaker again closed by saying you are the government, and just ensure that you take charge and take responsibility. I will also say that today there may be no more government support, but there is also no much of government inhibition. That is, they just leave you to do what you can do to be able to improve healthcare. I've talked about so in health insurance, the contribution that each person makes is called premium. That is a measure of amount of money that has been well designed by an actuary. An actuary is somebody who use data to be able to compute how much would be enough to cover a set of benefits. Health insurance is not meant to be arbitrarily computed. The premium is meant to be scientifically computed. It's meant to be done by a proper data analyst or an actuary or a very good health statistician. Payment therefore should be computed properly and premium determined same way. And it must be transparently done so that it can be visible to all those who work with it and can be trusted more. We encourage what we call pool system. Pool means that you are not waiting for people always to remember to come and pay, but you set up a system that helps them to pay with ease, a standing instruction sort of thing. So if, for example, they are using their bank or they are using their mobile wallet or they are using any particular tech-driven fintech, they must be able to put a direct debit instruction on it. So maybe it's weekly, just like we do Isuzu, Ajo, or periodic contributions. System can be debiting them little money. So I give example of an health insurance system where we have determined that it's going to cost about 8,000 naira per annum, or let's call it in dollar. Let's say it's going to cost about $20 per annum, and it's going to cover a particular set of benefits, primary care essentially. And then that has been set already, but people may not be able in the community to pay 8,000 naira at once. So we have just designed a system where people can actually pay just about 700 naira per month or 200 naira per week. And it's set up as a standing instruction on the system, and this gets collected on a weekly or a monthly basis, and that becomes useful. Another point that is very important is that if the health insurance pool becomes profitable, that is, there is more than what was used in the course of care over the year, the unused fund should be invested in risk-free assets. It's not meant to be just shared, because community health insurance is not more of profit center, endeavor. It is more of people center. It's more of mutual benefit system, wherein you can actually return back the gain on that community health insurance system back to the pool to expand the coverage of benefit or coverage of the people. So unused funds should be invested into risk-free assets. And transparency is very, 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 very key. Very, very, very key. Recently, the CBN launched a digital currency, which is going to take effect from October, where people now can actually pay e-Naira. They don't need to hold a coin. They don't need to hold Naira. They don't need to hold anything. They can actually begin to pay in digital currency similar to that of Bitcoin. But this is not Bitcoin, because this one has particularity of who is doing this. The KYC is very clear. It's not anonymous like that of the foreign digital currency. So this again is going to be a very good way for people to be able to do community health insurance payments. Data analytics is another important one. Like we said, data is king in the world of healthcare financing and insurance. Data is king. Data, data, data. The blood in health insurance is data. Data, right information that will be helpful to be able to determine what is needed to be done, how much to be paid, and that will be useful. And this has to be continuous. Unlike what we currently experience in the National Health Insurance Scheme, where the cost of care is fixed maybe for the past 10 years and it remains so. And so people have to cut corners. Clinicians have to cut corners because the cost of healthcare has increased. Medical inflation continues to increase year in, year out, because a lot of things that we do is imported. A lot of our drug or active ingredients are imported and is dependent on dollar that is continually changing in terms of effects. And so that will always be inimical to the success of an health insurance system. Therefore, data must be gathered on a continuous basis, and the premium is reviewed almost on an annual or biannual basis to reflect the current realities of the cost of care. Frequency of data is important. Frequency of data collection is important, and the analysis is very important. Health data analytics and algorithm will always be useful to be able to determine sustainability of an health insurance product. Enabling regulation, like I mentioned on, is also important. I would like to mention that, for example, in Nigeria, National Health Insurance Scheme is currently going through a new regulation that will soon be signed to law, hopefully, that is going to be called NHIC. And the bill is to ensure mandatory health insurance for all Nigerian citizens. What this means is that everyone will be required to be in one form of health insurance or the other in order to access healthcare. And those who are vulnerable or those who are not working or unemployed will be paid by one form of government or the other. That will actually improve participation into structured healthcare system And all of the other regulations like National Health Act, which prescribe that 1% of the consolidated revenue should be used to take care of primary health care of Nigerians. All of that will also come into play to be able to support this structure. Hopefully, this will ease the burden of healthcare and will increase the quality of the supply system all the same. And then that means that those who have set up community health insurance system in one way or the other, they will be the first to benefit from that drive because they would have learned the system, they would have been trusted, they would have done something very good. And so by the time the law, enabling law comes to play, it will just drive more traffic. It will just drive more people to be able to get served with them. And I'm very hopeful that it will be Christians, to be godly medical team like ours, that will be able to have put a lot of health insurance scheme in place in our various community with good network, such a way that by the time enabling law also comes into play, it will only expand that which you have already begun to do. Let me quickly just talk about implementing community health plan. Through, first and foremost, we need to set up a trustee. According to the National Health Insurance Scheme requirement, trustees must be made up of a medical personnel as well as a technical personnel from health insurance scheme that is data savvy, that is really a qualified health insurance practitioner, and of course, the village community leadership, so that we have people that will be all together to bring accountability to the whole scheme. And we also must ensure that the cost of administration is as low as possible. As a principle which I have tested over the past 5 to 7 years, I've seen that when the cost of administration in healthcare system is more than 20% of the total fund, that health system is likely going to fail. In health insurance system, if the cost of administration, which include cost of all the necessary non-clinical services, advertisement agency, and all of that, if it's more than 20%, the entire health scheme will not be sustainable over a long time. So there must be efficiency in the administration cost for that which is not clinical. The bulk of health insurance fund must be devoted to clinical. It must be devoted to the things that concern the curative or preventive or continuous management scheme of care. Once we deviate from this, because of the desire to be very, very profitable, we are going to have a challenge health insurance scheme that will fail and people will lose trust in it. So we recommend all the time, and in fact, WHO also recommended that it should not be more than 25%. I actually have seen that it should not be more than 20%. And it is possible to do it. I have done it at 7.5% effectively for the past 4 years. And I can actually push it further as we get more scale into 5% so that we can have more fund given to the real core care that people require. Again, surplus, like I mentioned, should be used to return back to community hygiene project. So in many communities, you can have issues with hygiene, potable water, the landscape, and public toilet, and all of that. So if there is any surplus, there must be provision in the constitutional framework of the community health insurance to use it to do basic things that concern healthcare. It's not something to be used to throw party or to be used to go and do election or something. No, it is something to be used to plow back into the health system, either increase benefits or invest into projects that can better the healthcare system of the people. My last slide, we'll be talking about, so what do we do as God's battle axe? We have seen that we require health insurance system is very important. It can work both in city, in urban area, as well as in community. We have examples of where we have actually seen healthcare work, both at community level as well as in the city and in towns and in big cities. We have also seen example of community health insurance outside this country where it has worked successfully because more people are aware and they are making contributions towards healthcare for the sick. We can also do it and actually scale it and make it rapidly growing in our own environment because it's going to give us a huge benefit. It's going to make us to be able to have access to more people coming to the structured care. It's a demand system. It pulls people. It pulls them early enough before their health care deteriorates badly. We know we do not have so much of emergency handling system in this country. we do not have enough equipment, even though we have great skills, we don't have enough equipment and we don't have great culture. However, but we can effectively drive health insurance system at community level. We do a lot of preventive. We allow people to come early enough to present themselves enough before things get bad. We're going to improve health outcome significantly. We will move from 54 to 70, even without having so much new equipment or so much new things, just because we change our methodology, we change our culture, we change the way we approach things. So I would say that the first thing we should do as God's battle axe, let's begin to set up community health insurance. Let's begin to set up community health insurance schemes. We can begin to collaborate together and set up community health insurance scheme and fuse it together with our clinical center. One thing I have seen in the practice, particularly in this part of the world, is that, which leads me to the second point, is that we do not embrace group practice. Everybody practices on their own, particularly in the private sector. Everybody owns his own clinic, his own hospital, his own pharmacy, and everybody just opened small silo clinics, and we could not do so much. There is a need for us to begin to collaborate, to have center of excellence that best of those doctors, majority of them are Christians, best of those physicians, best of those nurses, best of those matrons. Can we begin to pull together and have collaborations where we can have group practice, where we can do things very well, and we have center of excellence, and link it also to a well-structured community health insurance or a well-structured chain of community health insurance. We can actually also have like a network of chain of community health insurance and chain of clinic all put together in a group practice. And what it means is that it's like an hub and spoke model that Professor Choma talked about before. Things that are not going well in any particular spoke is quickly referred to the center of excellence. Health outcome will be increased significantly, and the cost of care will be optimized. It's not going to increase the cost of care, it's going to reduce the cost of care. We can actually make use of the little we have now more effectively. Even though the economy is challenging, but we're not depending on the economy of the world system. We're not depending on the economy of our nations. We're depending on God's own provision. But we have to use that provision efficiently. We have to use that provision in a way that we will have more for the little that we have or for the provision that we have. So we can actually do that through group practice, through effective collaborations. And I also want to mention that there are several people, Christians, who want to donate into healthcare, but they do not know how to structure it. They don't want to give individual. They don't want to just be paying for somebody who has surgery need, somebody who has cancer care need. They would have preferred to send in their resources that God provides for them into a structured system that can lead a lot of more people to access that healthcare. And it can only happen through structured community health insurance. It can only happen through structured prepaid system. And so when we structure our community health insurance and it works out well, many people will begin to donate. Just in the last couple of months, a huge company came and said, can you help me set up some community health insurance? I want to adopt 4 villages in 4 states where they're really poor. And he did. 20,000 people I want to adopt. Right now it's being deployed and people are excited about it. Many people want to support healthcare needs of people through what we call adoption, but they don't have structured system that they can leverage on. They know they cannot just succeed with just giving government the money. They cannot give they need to find who can deliver this effectively, efficiently. So if Christians actually partner together and we roll out such a thing, it will become a very effective pool, a demand system that enables us to get more people into proper health. And we need to prioritize by targeting communities with more dire needs so that we can have effective reach onto the people. Again, we need to improve our data and technology skills. We need to ensure every one of us will improve on data and tech skills, and there are various courses we can take in data statistics and technology and insight system that will enable us to be able to have a better grasp of health insurance. Every medical personnel, nurses, pharmacists, laboratory scientists, doctors, surgeons, every medical personnel needs to improve tech skill, particularly as it relates into health data and statistics. It's going to be making our work effective. We're going to be thinking both as a business person in our mind, as well as a Jesus heart that is compassionate. We must think efficiency, we must have business think, and data drives all of this together. I also want to mention that we also get ourselves involved in innovation. This is an area where all the Christian brothers need to collaborate to innovate a lot. There are a lot of innovation areas that we can actually enter into. We need to commence the process that look at research areas for medical improvement in our relevant areas and link it up into medical insurance system. It will really, really amaze us the possibilities of what we can do in healthcare if we collaborate together for innovation, because healthcare financing with innovation is going to begin to develop new things that can solve complex problems beyond what we think about. Recently, breast eye, an equipment that can diagnose rapidly the likelihood of breast cancer. It's not a mammography, it's much, much cheaper. It does it by isolation, was developed from NHS in London partnership and brought to Nigeria, was tested by government, was tested by private sector. And I look at it, it's just about $200, $300. And I look at it and I say, look, this is better done from Africa or from developing countries in order to be able to be suitable for our own variant or specific of strand of what we can actually do to dictate likelihood of breast cancer or likelihood of things that can actually cause a difference in the structure of the human tissues from our own local system. We shouldn't always depend on that which is done from Europe, from America, because at least because of their own genetic combinations, there will be peculiarity with them. Their own standard will be a little bit different based on their own lifestyle from ours. We can actually do this. And I'm always inspired when I see what is done, in Peace House Research and Institute of Center Excellence, which again tells us that there's a huge possibility of what can be done. Health insurance can work together through the funding of innovation for medical equipment, medical research, and that needs to be encouraged. Finally, today, NHIS supports organized community health insurance. They promote and encourage it. So community insurance that is well structured, NHIS can also even give some support funding. NHIS used to have a lot of reserve that is meant to be used for innovative ideas that can further improve the healthcare outcome of the land. Again, I end by saying that it is time for us as God's battle axe to ensure that the two sides of the healthcare are integrated together through effective group practice to pull the demand side as well as supply side and lead this work in this area so that we can have more people that will come to our own platform, the platform of healthcare delivery, which will become our own pulpit. So as we are working hard around the supply side, we must pull this demand side as well so that the two together will integrate and deliver the best of care to our people and give us opportunity to serve the interests of the master more. Thank you.
Good afternoon, Ma. Good evening, Ma. My question is for Bro Tokpe. First, I want to say thank you very much, sir, for the presentation. The role of health financing cannot be underemphasized, and I felt very privileged to have listened to that presentation. My question is about emergencies, health financing in emergency. So for example, someone has a proper health coverage, but the person is involved in an accident in a place where nobody knows the person knows, or the person even falls unconscious. So the person does not have a way of telling those that will attend to him or her, that I can actually pay for these bills, but just take care of me or something, and then I can take care of the bills. I don't know if you understand my question, sir. What solutions do you suggest, sir? And okay, one last question. This is for the organizer. Somebody wants to know how, if we want to reach out to BMC, how we can get across to them. Thank you very much.
Okay, we need. Please, can you unmute, sir?
All right, thank you. So let me quickly answer our sister's question. So in the design of community health insurance system, it must be designed in mind of exigencies. That is, a community member may actually travel, may have an accident, might be healed in the non-resident location where it's not a regular place of residence. So, and what is done is that a provision is made in the design of the premium such a way that we could pay for the cost of healthcare that happens outside the community. Prof mentioned about the fact that you can actually choose a hospital close to work and close to your home. And you can actually also still enjoy the benefits when you have traveled out of state. In the beginning, it will mean that you just leverage as the victim, you leverage on the provision that the medical system already has, that in all emergency, patient must be stabilized. It doesn't matter whether you are insured or you are not insured. That's the law, that's the provision that medical structure already has. So while it is now time to pay for such after the stabilization, the person is now conscious of family member, they can now reach out to the insurer to be able to pay. So in the design of the community health insurance, provision must be made for healthcare to be accessible outside the place of residence so that emergency can be covered up, can be paid for afterwards. So it's all meant to be part of the design. Thank you.
Thank you for this privilege to ask this question. My question goes to Bratope. How do you monitor each facility to be sure that they really have emergency care for all emergency, or at least accident emergency? That's the first question. Then my second question is, how do you reach out to, we are talking about community health financing, how do you reach out to rural areas? Then how do they also reach out to you as a company, since most of them are without Android and they are just there in the village? Thank you.
All right. Thank you very much, Sister Nike. I think, let me start from the second one, that how do you reach out to in the community scenario? So every community health insurance must be designed according to the peculiarity of the community. There is no general answer to all. So we have the basics of what must be done, but it must be configured or customized according to the peculiarity of that community. And by that, I mean, if, for example, I have a community where we have, let's say, about 500 people live in that community, and majority of them use non-Android phone, they just use basic phone that cannot do more than text and data. So it means that when I'm designing what to do, I will design something that will be able to be effective. What do I need technology for in that case? I need technology to be able to do simple things like USSD, so they can all do USSD. So they can all do transfer, they can all set up small mobile money agents. They don't have ATM machine, but they have a cash agent in that community. Almost every community in Nigeria today have cash agents, amazingly. The data we have right now shows that almost every community has within a 1 kilometer radius cash mobile agents. They don't need to use internet. They don't need to use stuff. They just use USSD. They just use simple device, and that is done. One important thing that must be attached to every community is a clinic center. And this is where collaboration is very important. We need to have effective and functional clinic that will tie the community health insurance into. Without effective clinic, there is no community health insurance. It is zero. It is null and void. So, and that's why it's important for us to collaborate, for us to have functional primary healthcare center, functional health center that we integrate with the community health center, and the functional center will grow. We grow because there will now be health-seeking behavior improved by the paying community. People will now begin to see that we prove it right, they get better result, performance is done. People are saying that, okay, so they have babies deliver. Before, 7 out of 20 people die when they are delivering baby. Right now, 19 out of 20 people leave. So you are using those performance metrics to be able to tell people this is a very good way for you to take care of yourself. Even if it means that you are going to first sell your first harvest to pay for your healthcare is important, and it becomes a part and parcel of the community system. So clinical must be functional. Clinic must be functional, as well as use adaptive technology that is relevant in that particular community. It could also be a payment system. Maybe they are always used to contributing on a monthly basis. Something that is very, very functional in that community can be leveraged on for payment and collection. And the minimal technology that is possible in that place can be done. But you can also realize that there's a lot more that communities can do now than in the past. And I think the first question is on, sorry, please remind me this first question. Sister Bola? Accident?
Yes, that was the accident one.
Okay, so she asked about the quality assurance of hospital, whether they are able to take care of accident or all of. One of the role of health insurance system is to do quality assurance audit. Every clinic that you partner with, every hospital you partner with, we normally do audit to be able to check, do they have all the capabilities that they planned, that they are meant to have. Before you even sign them on, they are meant to have basic requirements according to the enabling law. And then you continue to check them on a periodic basis to be sure that they are still having it. If they don't have those facilities anymore, you either take them out of the network or you help them to get those facilities as much as possible. And that's why good relationship with the healthcare center is very pivotal to the success of effective integration of community health insurance system. So audit must be done not only by the regulator of the health center, also by the health insurance system that is designed. So all community health insurance system must always check the facility that is giving care to the people to be sure they are compliant with all of the things that are set.